speaker is Dr. O.P. Yadav.
Hello.
Please, this session is over. Please, everybody.
Thank you. Thank you.
Thank you, Dr. Gupta. So our next speaker is Dr. O.P. Yadav. Please share his CV slide. So Dr. O.P. Yadav is a globally renowned cardiothoracic surgeon. But his peculiar feature is he's more interested in cardiology than cardiothoracic surgery. And that is his unique feature. Currently, he is CEO and Chief Cardiac Surgeon at the prestigious National Heart Institute, Delhi. He's Director, All India Heart Foundation. He is Fellow of the Cardiological Society of India, Indian College of Cardiology, and Indian Association of Cardiovascular and Thoracic Surgery. He is Editor-in-Chief, Indian Journal of Thoracic and Cardiovascular Surgery and Cardiology Today. He is eminent NBE Alumni Award 2014, Dr. B.C. Roy National Award 2016, CSI Lifetime Achievement Award Delhi 2023, and Lifetime Achievement Award Society of Minimally Invasive Cardiovascular and Thoracic Surgery. So he will be talking on CABG current status in 2025. Over to Dr. Yadav.
Thanks, Professor Manoria, for this kind invite. Is my slide visible?
Not yet. Yes, it's okay.
Okay. Well, ladies and gentlemen, my greetings. And before we delve deep into the matters at hand, current status of CABG into 2025, let's first have a look at certain incontrovertible facts about Indian CAD. We have a very florid kind of atherosclerosis, and therefore our arteries are diffusely diseased with a lot of inflammation, with neurovascularization and macrophages infiltrating our coronary walls. And therefore, it becomes very important for decision-making that we risk stratify our patients well. The ischemia trial showed that it is not the degree of ischemia which is important, but the extent of atherosclerosis which decides the outcomes. And it can be seen that the mortality associated with one vessel disease is around 1.5%, but with three vessel disease, it marches up to almost 8%. Also, ejection fraction less than 50% is a very strong risk factor for mortality, unstable symptomatology, low exercise capacity, complex ventricular arrhythmias on exercise, and abnormal blood pressure response are other high-risk features. We have to keep this in mind when we decide on whether to operate on a patient. For any revascularization, our goals are essentially three. One, we have relief of symptoms for the patient. Second, we prevent adverse events. And third, improve long-term survival. Now, it has been shown that revascularization improves angina and quality of life. There is no debate. But increased survival is very nuanced and has been shown to occur only a limited subset of patients where there is huge amount of myocardium in jeopardy, like left main and three-vessel disease, and patients with LV dysfunction. And therefore, if you look at the two recent guidelines, American and the European, to improve symptoms, CABG has been granted a class 1A indication. However, to improve outcomes is a very nuanced indication. LV dysfunction, ejection fraction less than 35%, both guidelines give class 1 indication for surgery. But in patients with mild LV dysfunction, European guidelines give a class 1 indication, but the American guidelines have downgraded CABG and PCI also from class 1 to class 2A, and patients with normal LV function, irrespective of left main, irrespective of proximal LED, American guidelines have downgraded the revascularization, both CABG and PCI, from class 1 to class 2B. Now, that's a very low class. And the European guidelines of 2024, the most recent one, still give it a class 1 indication. So all the professional societies world over have protested. We also have submitted our protest against this. And for the moment, we follow the European guidelines because even the ischemia trial 7A results, which were not available when the American guidelines were framed, are now available, which show that intervention in these patients improves survival. So revascularization, especially CABG, is a class 1 indication even to improve outcomes in these patients. Now, the debate between CABG and PCI is really an artificially created one. If you look at the current European guideline, just out 6-9 months back, CABG is recommended when a patient is diabetic, has got severe LV dysfunction, when a distal left main is involved, or multivessel disease, which has got a high syntax score. By the same token, PCI should be prioritized whenever the surgical risks are high, whenever we have 1 or 2 vessel disease which does not involve proximal LAD, and in patients with left main, when the syntax score is low, PCI is a wonderful option. So this fight between the two actually should end. Now, what are the conduits that we use in bypass surgery? Venous conduits can be from the leg, especially the typical long saphenous vein. Sometimes we use short saphenous vein. We also can go into the upper extremity and use the basilic and the cephalic vein. Arterial conduits are essentially autologous. Internal mammary and the radial artery are very widely used. Gastroepiploic and inferior epigastric arteries are lesser often used. But virtually any and every artery in the human body has been tried in bypass surgery, including the splenic artery, the gastroduodenal, left gastric. All of them have been tried, but they have not really found much application or widespread application. Non-autologous graft using bovine internal mammary artery and artificial conduits have really flattered to deceive and have not come into clinical use. As it stands today, our current practice the world over, we find saphenous vein occupy the prime position. 80 to 90% of the grafts are saphenous vein, and unfortunately, total artery revascularization occurs in under 10% of patients. But the problem with the vein grafts are that before the patient leaves the hospital, almost 5 to 10% of them are blocked because of technical issues and because of thrombus formation. And by 10 years, we find nearly half of these grafts have failed. Certain technical improvements have been made. For example, harvesting the saphenous vein with its surrounding fat, fascia, and lymphatics. And it has been shown that it improves the graft patency rates. But by far and large, vein we consider inferior to arterial grafts. Now, endoscopic harvesting of the veins, it does reduce the wound complication rates, but the concerns regarding endothelial integrity remain, and the long-term patency of these endoscopically harvested conduits is not settled as yet. So by far and large, IMA remains the gold standard for multiple reasons, and we find that its patency is excellent. The yellow line you can see is absolutely straight line, almost at 16 years. 95% of these grafts are patent. And if you look at the vein graft, the red line, it keeps petering out, and really half of them are blocked by 10 years. This improved patency of LEMA translates into improved survival and reduced adverse outcomes. And it has been demonstrated in n number of observational studies that bilateral IMA is better than unilateral IMA. However, when we look at the randomized trial, the ART trial, there was no difference between bilateral IMA and a single IMA. But then this trial was a flawed trial. There were multiple issues with it, including there was a high crossover of single to bilateral and bilateral to single IMA. So when a sub-analysis of as treated group was done, we found that there is benefit of use of bilateral IMAs. However, bilateral IMAs should be used with due caution in patients who have morbid obesity, who are insulin-dependent diabetics, and patients with severe chronic obstructive airway disease where the lungs may be inflated and the pedicle IMAs can get kinked. Therefore, it should be used with caution. How do we choose for the second arterial conduit between the radial artery and the rima? Both have equivalent results, but if a patient has high risk of mediastinitis, then probably radial artery is a better conduit. And if the patient has got moderate 60-70% stenosis, when the radial artery can go into spasm, therefore in these patients, a right memory may be a better conduit. Now, gastropelvic artery runs along the greater curvature of the stomach, and it has been shown to have excellent patency in very competent hand, especially excellent results have been published by Suma et al., but it's technically demanding, and therefore it is used only as a conduit to go to when you have no other conduit available. What are the various techniques that we use in bypass surgery? Now, the doubts raised for off-pump surgery by the Ruby trial have been by far and large paid to rest by the coronary trial by Lamy et al., which has shown that there is no difference in outcomes between off-pump and pump surgeries. Even in an Indian study from Kochi, the degree of completeness of revascularization was same in both, and there were salutary early results where the observed mortality was just 1.5%. And the long-term results, 16-year results, have been published by the Bristol group, and which have shown there is no difference between pump and off-pump surgery. So we strongly believe it is the surgeon and not the technique. If you are comfortable doing off-pump, it's a wonderful technique. Minimally invasive surgery has come into vogue because of essentially sternotomy has problems with respiratory problems, with the chest wall instability, with deep sternal wound infections, and therefore all kinds of lexicon have been devised for various minimally invasive techniques. But by far and large, what we have achieved till now is that they are feasible, can be done with a very, very low morbidity and mortality. However, we must not forget it is the best man, Bonatti et al., writing 25 years experience of minimally invasive surgery, that it is technically challenging and the learning curve should not be underestimated. Also, we must realize that there is no hard endpoint benefit of minimally invasive surgery, no benefit of mortality or myocardial infarction, and long-term results are exactly the same. Also, it cannot be used in all patients. Emergency situation, patients with chest wall abnormalities, patients with chronic obstructive airway disease, morbid obesity, minimally invasive surgery is by far and large contraindicated. Robotics is a very niche specialty. Most centers who do robotics in India are only harvesting a conduit, and virtually none is doing a coronary anastomosis with it. But a few overseas centers are doing with using nitinol clicks, and in very, very nuanced hands, it may have a good result, but by far and large, it has not found increased percolation in the society. Now, hybrid coronary revascularization using IMA to the LAD and angioplasty to the back of the heart has not been shown to produce any hard outcome benefit, and the only advantage is reduction in the hospital stay. Apart from that, there is no benefit, and therefore guidelines give it a class 2B recommendation, and it can only be used in high-risk subset of patients. However, one thing we are very certain, and all guidelines mention, that irrespective of what technique you use, we must always prioritize complete revascularization. It improves outcomes and has been given a class 1 indication both by the American and the European guidelines. Outcomes of CABG are excellent. All-comer studies, the mortality range is around 1.5%, but the biggest problem with CABG is the high incidence of strokes of almost 1.5%. But this incidence of stroke can be used by using off-pump techniques and by using what we call anaortic techniques, by using lima-rima Y, so that there is no top end placed on the aorta, so there is no manipulation of aorta, no cross clamp, no side biter clamp, and therefore the stroke rates come down. However, the con factor is that when you use a lima-rima graft, there is only one in point or intake, and therefore we are putting all eggs in one basket. If it fails, then the entire myocardium can be in jeopardy. The long-term results of CABG are definitely proven and excellent. What about the results of CABG in certain special subsets? Stitch's trial has categorically shown that CABG produces survival benefit in patients with LV dysfunction. There is no debate there. The only problem is we still do not have the answer that should viability testing be done in these patients with LV dysfunction. If you look at observational data, the answer is yes, it should be done, but randomized data does not support it. But we seem to have sufficient evidence today that there is an equipoise at 10% of myocardium. What it means is that if we have viable myocardium less than 10%, then revascularization does not improve outcomes and medical treatment may be better. But if the viable myocardium is more than 10%, you can see 15 and 20 survival curves diverge, and the advantages of revascularization are much more over medical treatment. Diabetes is an altogether different ballgame, etiopathologically, anatomically, functionally, and it has been shown in a number of trials, incontrovertible evidence that CABG reduces all-cause mortality. In hospital mortality is same as compared to non-diabetics. Number of studies have shown that, but long-term mortality is increased. Here we can see the survival in the diabetics, the red line is worse than the non-diabetics, and the insulin-dependent diabetics, the yellow line, do worse than the non-insulin-dependent diabetics. Unprotected left main there is no debate at all. CABG is very safe, and it has been shown to give excellent long-term results, and therefore should be prioritized, especially if it is associated with multivessel disease, there is distal left main involvement, or if the Syntex score is more than 33. Now, women are a complex subset. They have higher comorbidity. They have physiologically more microvascular dysfunction, smaller coronaries, diffuse atherosclerosis, and the early outcomes in these ladies of surgery are relatively poor. They have 2 times higher mortality as compared to men. They have higher graft failure rates, and these graft failures are associated with increased adverse outcomes and increased mortality. Even in our own study, personal study of 3,500 patients published in the Indian Heart Journal, we found in-hospital mortality was 3% against 1.8 with men. But off-pump surgery seems to reduce this mortality and negate the negative effect of gender. ACS PCI is the undisputed king, no question about it. However, should PCI fail and patient have recurrent ischemia, or if the patient has mechanical complication of myocardial infarction, then surgery assumes a class 1 indication. Now, there must be a situation where we have no option for the patient. Such diffuse is the atherosclerosis that neither the patient is suitable for angioplasty nor bypass surgery. In these cases, we can do what is called, as against coronary artery bypass surgery, we can do what is called coronary venous bypass surgery. Now, this is based on the fact that coronary veins do not have any valves. So when you retrogradely perfuse the coronary veins, they perfuse retrogradely all the muscle elements, and therefore, if you have to perfuse the LAD territory and LAD is not graftable, we can put a bypass graft to the great cardiac vein, and its drainage to the coronary sinus is blocked, and then all the blood that comes goes into the myocardium. Similarly, if you have to revascularize PDA, we can graft the middle cardiac vein. So coronary venous bypass can be done in these patients. Well, bringing up the rear, what about the timing of stopping of the drugs before surgery? You as physicians may be interested in that. GP2B3A receptor antagonists, eptifibatide and tirofiban, we just need to stop for 4 hours. That fear of these GP2B3A should go away. Even if you have to operate within 1 hour, generally, they don't create any major problems. Epsiximab, if we have time, should be stopped for 12 hours. Clopidogrel should be stopped for 5 days for an elective surgery, ticagrelor for 3 days, and prasugrel for 7 days. However, if it is an urgent CABG, never should a CABG be denied because the patient is on antiplatelet or GP2B3A inhibitors. And also in any elective surgery today, it's a class 1 indication to continue aspirin throughout the period, right to the point of surgery. Even on the day of surgery, we give aspirin in the morning. Aspirin has been shown to reduce mortality and improve outcomes. And in doses used less than 160 milligram percent, it might increase the bleeding a little, and you may spend 10 minutes extra securing hemostasis, but it does not translate into re-exploration or any need for extra blood transfusion. So aspirin is safe and should not be stopped before surgery. Lastly, the follow-up is very important. We all know that bypass is a palliative procedure. So lifestyle modification and risk factor control are sine qua non of good outcomes. Unfortunately, there is physician inertia as well as patient compliance is a big problem, and we find only 50% of patients adhere to pharmacological treatment and barely 20% adhere to non-pharmacological treatment in form of regular walking and cessation of smoking. Therefore, it is a class 1 indication that we take the use of mobile health initiatives, bring about behavioral changes in the patients. Also, we should simplify medicine regimens by using polypills. Patient will not like to take 3 pills, and also involve the family physician and the family members in patient education. Aspirin should be given lifelong class 1 indication according to both guidelines. However, American guidelines give class 2B recommendation for dual antiplatelet after CABG, and this is based on the CURE CABG study, which it was shown that dual antiplatelet given for 1 year, mind it, only for 1 year, reduces cardiovascular death and morbidity. However, beyond 1 year, there is no evidence of continuation of dual antiplatelet for CABG. Triple antithrombotic treatment is contraindicated. It's only very rarely when you have a mechanical valve or recurrent thromboembolism, when you are pushed to the wall. In that situation, you may use a triple antithrombotic, but then it should be used for a very short duration with frequent INR monitoring, and the INR should be kept relatively low between 2 and 2.5. Otherwise, by far and large, we should avoid triple antithrombotic. A recent COMPASS trial has tried rivaroxaban plus aspirin, and it has been found to be useful for these patients instead of using a triple antithrombotic treatment. Statins are a class effect, and they are class 1 indication. We have to use high-intensity statin in the maximum tolerated dose so that we bring the LDL down to less than 55 milligram percent or more than 50% reduction from the baseline. If we do not achieve this, then we can have stepwise escalation to ezetimibe, PCSK9, bempedoic acid, and so on and so forth. However, niacin, fibrates, and omega-3 have not been found to be of any use. Calcium channel blockers have to be used routinely for 1 year for all radial arteries to prevent spasm, and it is a class effect. You can use any calcium channel blocker, but a recent study just come out last week from the China, the ASTRAP trial. They have shown that nicorandil and isosorbide mononitrate are better antispasmodic than calcium channel blockers, and they have said they should be used instead of calcium channel blockers. Beta blockers are class 1 indication, essentially to reduce postoperative arrhythmias and for secondary prophylaxis. They are more useful in patients with history of myocardial infarction, LV dysfunction, and heart failure. But again, the evidence is there for 1 year and not for beyond that. So in nutshell, all patients must be on afterload reduction, on beta blockers, on statins and antiplatelets. Some patients where there is an indication, they can be put on MRAs, they can be put on SGLT2 inhibitors and GLP-1 agonists. There is no role of nitrates and vasodilators and diuretics as a routine. Mind my words, as a routine. However, if a patient is symptomatic, then these may be indicated, and in an occasional patient where there is a specific indication, which obviously a cardiologist will take a decision, mechanical support may be required. Cardiac rehabilitation is a class 1 indication, and it must begin as early as possible and must last at least for 4 to 8 weeks, as it is cost effective and ensures return to employment. In fact, a paper which has just released this morning, and I included it in this pack only half an hour back, it shows that it is not the reduction of cholesterol to whatever levels I just told you, it is the residual inflammation which is more important. Therefore, besides reducing the cholesterol and the LDL to less than 55 and all those targets, we must make sure that the CRP levels drop. And for that, believe you me, ladies and gentlemen, all these alternative forms of holistic therapy are very complementary to CABG, and they must become a part of our armamentarium. So to conclude, my take-home message, ladies and gentlemen, is that Indian CAD is a very florid CAD, which is a spectrum. At one end, it may be a trivial disease seeking medical treatment, but the other side, it may be a high risk, which goes for intervention. So risk stratification is important, but all patients of CAD must have, by default, medical treatment advised for them. Only by design we must choose intervention, be it CABG, be it PCI. And once we choose an intervention, technique is immaterial, whether you do pump or off pump, whether you do, minimally invasive or sternotomy, you must prioritize only two things and ask a surgeon. One, they should give arterial conduits, and second, complete revascularization. And lastly, we must rehabilitate and follow up these patients well. Otherwise, all the good work comes to nothing if the follow-up is not satisfactory. Thank you very much.
So thank you, Dr. Yadav, for a very informative and exhaustive discourse on current status of CABG 2025. The first issue is why internal memory artery is virtually immune from atherosclerosis. So what is your viewpoint? That's why the patency rates are excellent, whether it is Lima, Rima, or combined.
So there are multiple reasons for it. One of it is that it is an elastic artery as against radial or gastroeploic, which are muscular artery. So being an elastic artery, the tunica media layer of it is much smaller than in the other arteries. Secondly, it has a complete internal elastic lamina. There are no perforations or breakdowns in the internal elastic lamina, so the smooth muscle cells are not able to transmigrate from the media into the subendothelium. And thirdly, it elutes nitric oxide, which is what we used to call the EDRF, or the endothelial derived relaxation factor, which is now we know. And then there are multiple things like, it is caliber is more matching the coronary artery, it provides laminar flow, and so many other factors come into play.
You said bilateral memory grafts are done only in 10% or 5 to 10%. What are various reasons? Is it that the complication of, say, sternal necrosis, other complication or more is technically difficult? What are various reasons so widely practiced? Bilateral memory grafts.
So, I mean, it may not be politically a correct answer, but the real fact is that internal mammary artery takes time. An average internal mammary artery would take 45 minutes extra over saphenous vein graft. And if you have to do 2 internal mammary artery, we will take another 1.5 hours. If you have to add a third arterial graft, the gastroeploic, another 1 hour is added. And most surgeons will not willing to spend that extra time. And that's why we have been saying that it should be incentivized and it should be made a quality matrix. So the government and the insurance company should say that for all vein revascularization, your fees is 10,000. If you put one mammary, it is 12,000. If you get 2 mammaries, it is 15. And if you put triple arterial, we give you 20,000. And you will see this number will jump from 10% to 90%. So this is the sad part of it, that we, the surgeons, more often than not, we are not willing to put that extra effort because there is no financial remuneration or incentivization for that extra effort. Rarely a patient may have insulin-dependent diabetes, grossly obese, and other contraindication where you may not use bilateral IMA, but in that you can use IMA with single IMA with bilateral radials. Still you can give total arterial. So I think it is totally inexplicable and inexcusable on the part of surgical fraternity not to use arterial grafts.
How common is sternal necrosis with bilateral memory grafts?
Bilateral memory grafts for insulin-dependent diabetics The deep sternal vein infection and sternal necrosis stands at 8%. Non-insulin dependent diabetics, it is 3%. For non-diabetic, it is around 1.2%. So as the diabetes status worsens, your diabetes, the wound necrosis rates increase.
CABG is a standard position used across our country and the globe. Now, what is the status of redo CABG surgery? What are the problems associated with redo CABG? And what is the average mortality rate of a redo CABG?
So one, sir, you have asked 3, 4 very important questions and time was short, so I had purposely not included redo. Redo is occurring. We found that the redo numbers have come down lately a little. One, because the total arterial revascularization, which stood at 1 or 2% 20 years back, has now come to 5 to 10%. So the number of redos when you use arterial grafts will obviously come down. Secondly, PCI has become very standard and technologically advanced procedure. So a lot of those cases are now being handled by PCI. So redo today is just about 2 to 5% of our total workload of a cardiac surgeon in 2025 will be redo cardiac surgery. Number 2, regarding morbidity mortality, I have heard and I've seen articles about that redo does not add to mortality. I do not agree with that. Even if you look at the STS all-comer national database of the America and a lot of centers coming up, the mortality with redo surgery increases dramatically. And currently the mortality stands at around 3 to 4% in a normal LV with redo surgery. The problems are essentially of 2 or 3 kinds. One, these patients obviously are elderly now because first surgery they had at the age of 60 or 70. So now they're having second surgery 10 years later. So more comorbidities and more subsystem involvement is there. So they are sicker population. Second, when you re-enter the sternum may be stuck to the right ventricle. So there is a potential to damage of the heart to cardiac structures as well as to patent grafts. Suppose there is one IMA patent and other grafts are blocked, then you can damage that IMA. That is a very major problem. And third problem with redo CABG is paucity of conduits, because in the first surgery, a person may have exhausted most of the best conduits and you are left with suboptimal conduits now. So these, I would say, are the 3 major problems with redo.
Synthetic conduits, as you said, are not in practice.
Well, they are not in practice. We always keep them. A PTFE, polytetrafluoroethylene, 3 to 4 millimeter thin graft. And once I would say in my lifetime of almost 40 years and 18,000 bypass surgery, I can recall only 3 instances when I've used a synthetic graft. When I had nothing, I tried all legs, everything, and made 100 cuts and I couldn't get any artery. And yet we had to bail the patient out. We put synthetic grafts. They are shown to have very high occlusion rates of almost 50% within the first 3 to 6 months.
But the other issue is sometimes you have associated carotid vascular disease also. So you do CABG first, carotid first, or both together. What is your strategy?
So this is a very long discussion, sir. Number one, the 20 years back when carotid was becoming such a hot thing and we at the very sight of carotid, we would straight away go for carotid endarterectomy. And then PCI came and you started doing angioplasty of the carotid every single case before they sent. Now all this has been given up. In 2025, if the patient is asymptomatic, no matter whatever carotid disease you have, you would probably not touch the carotids. You can have the advantages when we do off-pump surgery. You can keep the blood pressure high. You can do NIRS, or what is called near-infrared spectrometry. You can keep, by this, the anesthetist keeps monitoring the cerebral oximetry and performance so that if any time you are uncomfortable, then you can immediately raise the blood pressure and take remedial action. So carotid endarterectomy should only be done in symptomatic patients having critical unilateral stenosis, and we would do carotid endarterectomy first, leave the wound in the neck open, because if we close it straight away, when we give subsequently heparin for CABG, then there can be bleeding under the skin flap. So we do endarterectomy, leave the skin open, perform the CABG, reverse the heparin with protamine, and when the chest is being closed and hemostasis has been secured, at that time the skin and the tissues are closed in the carotid site also. So you do the carotid first and bypass later in the same setting. However, there are all three modules available and everyone has. Some do CABG first, carotid later, staged. Some do carotid first, CABG later, staged. And people like us do simultaneous, carotid followed by CABG in the same anesthesia.
Seen some patient complaints of cognitive decline. So what is the average percentage of patients who get cognitive decline post-CABG?
Well, I would say that we are not checking these patients aggressively and checking on these cognitive declines. Our knowledge of cognitive decline has come essentially because of TAVI. It's only when routine we started doing, then we realized, and some evidence is coming from PCI. So CABG we do not do, but for sure, you can be assured that 100% of patients have microemboli going into the brain. There is no question about it. And these microemboli would certainly be much more if you are doing aortic handling. So if you use Lima-Rima-Y, then you do not do any aortic handling, then the incidence of cognitive decline is much lower than otherwise.
Is there a role of artificial intelligence emerging for CABG?
Yes, artificial intelligence role is emerging for everything, especially for whenever we want to re-enter the sternum for redo surgeries. Artificial intelligence generated information regarding the CT thing is very important. Artificial intelligence can also be used for follow-up of the patient, for looking for the ECG changes post-operatively and seeing if we can identify patients who are going to get life-threatening arrhythmias or sudden cardiac arrests, VT and VF. So those kind of things, artificial intelligence can also be used for sugar monitoring and treatment post-operatively. So artificial intelligence will obviously be important for diagnostics, for therapeutics, and it's going to be the future even for the follow-up of the patients.
So lastly, are there any unresolved issues with CABG?
Well, unresolved issue itself is that CABG is a palliative procedure, and I'm convinced, very much convinced, that these are not the treatments of the future. It will be something like peptic ulcer surgery. We trained with gastrojejunostomy and vagotomy as cardiac surgeons. As a general surgeon, my first surgery, barring hernia hydrocele, major abdominal surgery, was a ruptured or perforated duodenal ulcer. Now, they're things of the past. Well, I can foresee that there will be a day when molecular and those targets can be found, when genetic manipulation can be done, where CABG will be totally out, including PCI, and we will not have in 20 years' time a term called CABG, and we'll laugh at what we are doing today.
The future may be no plaques, no atherosclerosis.
Yes, sir.
So thank you very much for the very wonderful discussion. Thank you, Dr. Yadav.
Thank you very much. Much appreciates.